So I have the pleasure of challenging some of the stories that we hear, the discussion we have around the management and delivery of care. And I'll be talking about how we look at the myths that there are out there. And we know that a myth is really a widely held belief, but is basically false. And so this document sets out to challenge some of those areas. And we really need to think about the practice that's going on and where there is ritualized behavior. So some of these challenging definitions. The first one I'm going to be looking at is this myth. A wound must be present on the limb for at least 6 weeks to be classed as a leg ulcer and therefore treated with compression. Now, I know really where this came from. There's often a little bit of historical narrative to a myth, but we need to put this one to bed. There is no reason to wait and delay treatment. The thing is about a wound on the leg is it is on the leg. It's not a traumatic lesion on the arm. And one of the things we have to really get to grips with is the impact of a wound on a leg and the influences on that leg, which is about gravity, and it's about the hydrostatic pressure. So any wound on the leg benefits from local support in the form of compression from light to strong, depending on the issues in their lower limb. So we need to stop this delay because we see it in the stories we hear about patients. They go, it's not an ulcer, I haven't had it for long enough yet. You've got a wound that needs management. Let's see what we can do early to prevent it tracking along the chronic trajectories. So this is also an interesting one, this old myth that we hear. And we know where this comes from. Historically, of course, we use ABPI as a measurement for knowing whether it's safe to put compression on. Unfortunately, the way we speak in education sessions sometimes means that people see Doppler being okay equals it must be a venous ulcer. That's not truth. A Doppler tells you, the ABPI tells you about the ability of the limb to tolerate compression bandaging. It does not diagnose the ulcer. And we need to be very, very clear about that. But we hear it all the time. And so it's incumbent on all of us to correct that and use the correct language about what an ABPI is about. Assessment is part of a jigsaw. And we need to put all those pieces together and not confuse the fact that just because they can officially tolerate compression, that it's a venous leg ulcer. It could be vasculitic. It could certainly be pyoderma gangrenosum. So don't be put off the scent in your investigation of cause. This is an interesting one. Thankfully, I haven't seen this very much, but it was common enough to bring into the myth section that superabsorbent dressings should not be used under the compression bandaging, but should be used over compression if required. Is this something that people see? Well, I think it's rather odd, I have to say, because, why would you want, if that was on your leg, you would want the exudate tracking all the way through those layers to the dressing on the outside. I think this comes down to the fact that people think that we need to be really, really vigilant about the ankle width, which is fine, but let's not pretend that we know the amount of compression that the limb is getting from your technique. We don't, even with the sub-bandage guides on various bandages. So, let's just accept that actually there's a lot of variation there, and it's about the key theme about understanding the theory behind compression, which is the wider the limb, the less the compression gives to that limb. So we can do that, and you need to be skilled enough to vary your bandaging accordingly, but let's not put loads of superabsorbents on top of the bandages. No idea where that came from. People do use way too much wadding, I have to say. That's my personal opinion. In Europe, you hardly see it used at all. So, there's some critique there to be had. So this is my favorite, so I'm going to spend a little time on this one. Reduced compression is therapeutic for venous leg ulcers. I have a particular issue, as I think the whole of the panel did, with the increasing use of light compression and reduced compression, whatever you want to call it. So whilst there is that old saying, you know, some compression is better than none, let's again not pretend that we're putting compression on that's therapeutic if we're using light compression. We're tickling the leg, okay? And it might look lovely, and it might stay up, and it might be comfortable for the patient, but it's not therapeutic. And we have to challenge this. So when we look at the SIGN guidelines, we say that high compression is around 23 to 35. It doesn't even mention the magical 40, by the way. But there is a disagreement, actually, if you critique the literature and other consensus documents around what high compression is. And if light compression or reduced compression is under 20 millimeters of mercury pressure, you can see that in international consensus, they describe this as mild. Do you want to be putting mild compression on the limb? Andrea Nelson calls it homeopathic, which I thought was fantastic, so I always have to attribute it to her because it is a great quote. But strong compression here is 40 to 60. That's 40 to 60, not 40, it's 40 to 60. So there's some disagreement here, but what we are in agreement about is that light compression is reduced therapy. You're not creating a therapeutic environment. So here's just a little slide here about a particular bandage regime that has a standard product and a reduced, so high compression and a reduced product. And you can see that over the years, the spend, that's what bandages have been bought in the NHS over the years, is reducing the high compression product and increasing use of reduced compression. Have we got more patients needing reduced compression? I don't think so, not necessarily, but it's because we think some is better than none. But the impact is on wet legs, unresolved problems, daily dressings, morale in district nursing shot, and we wonder why we're not having the impact on leg ulcer healing that we think we should have after over 20 years in this game. Inelastic bandage is not suitable for immobile patients. Again, this started because about the impact of inelastic systems on the calf muscle, fantastic impact, but let's not take it to the length that it goes to, which is equals not for immobile patients. It's not true. They're very effective. And here we have a PicoPress monitor demonstrating that someone who's immobile, they just need to do ankle flexions, toe curls, sitting up in bed. The other one is standing. Just standing increases the sub-bandage pressure. It's therapeutic. It provides a massaging effect. Hosiery kits are only for self-caring patients. Again, what we've done in this document is say we can use this as first line. First line for those who've got a pretibial laceration, hematoma and so on, get some support on the leg. It will stop infection and stop them going through cellulitic admissions. For hematoma, you just got to get the hosiery on quickly, and there's very good evidence for them being very therapeutic for ulcers around the gaiter region, and we've spelt that out within the document. And my final one, whoops, sorry, is about compression to the foot. Now, this is a strange one. Actually, I have no idea where this started, but I hear it from patients and nurses all the time that, oh, no, you don't apply compression to the foot. You apply compression from the turn that comes out of the ankle. This is not right. You apply higher compression from the turn out of the ankle, but you need to compress the foot. Whilst we are not addressing the foot, you see this impact. You see squeezing of the edema down to the toes, creating lymphodematous toes, creating more problems and more erosions. We've got to stop this. We've got to compress the foot and allow the bandage to work on the foot pump as well as the calf pump. We're creating real damage to the toes by the elastic effect of compression at the ankle if you don't address the foot.